To hear from all our panelists. So I'm Monica Yepes-Rios, so I'm an internal medicine physician with the Cleveland Clinic. My clinical practice is centered on the west side in Ohio City with Ohio City Hispanic Clinic, so really dedicated to serving the Hispanic community here in Cleveland. Unlike our panelists, I'm not originally from Cleveland. I've been here 5 years, lived kind of around the country. My husband had served in the Navy, so we were kind of all over the place. And have served different Hispanic communities in Washington, D.C., a more Central American community in California, right on the border with Mexico. My office, I used to see the Mexican flag every day. And now here, where we have a mix of Hispanic community, mostly Puerto Rican. So I do have some slides that I think just kind of visually might help a little bit walk us through the Hispanic health. All right, All right, so first I kind of wanted to start with what do we mean by Hispanic health? So there's actually, you may hear Latino, Hispanic, there's kind of an emerging terminology that hasn't quite gone on, which is LHS plus, which is Latino, Hispanic, and plus, which I'll define in just a moment. So if you think about it, so Latino means like Latin America, so kind of Central South America and some of the islands. And Hispanic really is derived from the Spanish language. So that connects us all the way back to Spain. And in Latin America, there's some countries where Spanish is not the primary language, like Brazil, which is a big country there. So we can kind of put it all together as LHS plus. But as you can imagine, just looking at the map, the diversity is tremendous, right? So comparing somebody way at the top of the map to the bottom or all the way across Spain, almost makes no sense. But what do we do? Many have in common is the language, although again, that's not necessarily uniform. So I just kind of wanted to kind of center it on that. And the plus means, again, there's so many countries and just so many subcultures within the countries as well, that it's important for us to keep that in mind. The Hispanic population is also one that is growing, and by 2045, actually not really necessarily a minority anymore. So that's important for us to see across the country. The Hispanic community is increasing as well here in Cleveland and towards the west side as well. And it's a population that's generally young. So on the left side, you have in red the U.S. Hispanic population, which is more in the 15 to kind of 45 age group. So it's a young population. And then when we look at what is the population, what kind of conditions tend to afflict the population are what we consider chronic diseases like diabetes, being overweight, high blood pressure as well. And it's a community that, depending on where they're from and what their kind of resources are largely uninsured or underinsured. So you put together chronic diseases and poor access to care, and you can imagine what that can do for the community. Over COVID, we've heard kind of how it affected different communities. Probably for the first time in a long time, we actually saw a decline in life expectancy all across the board, and the Hispanic community were significantly affected by that, projecting that they lost actually three years of life. So this is obviously concerning and sad to see the Black community also got very much affected. But interestingly, there's something called the Hispanic paradox. So despite what I just showed, it's a community that has pretty significant medical conditions, chronic conditions, and sometimes not perfect or not good access to healthcare. They actually may have longer life expectancy, except during COVID. And you wonder, how can that be? So some of the theories could be that the Hispanics who do emigrate here to the country are potentially healthier and were able to make it here to the country. Sort of what the salmon bias, the kind of swimming upstream and being able to make it here. It is a community that is very tight, really relies on their social support and their families, and that might just give them a lot of strength, and actually surprisingly has kind of lower tobacco use. But this is again despite the disease burden. So it's a bit of it's called the Hispanic paradox, but it might be very different community to community. So as as you look at the map, the important thing is, well, who is my community, right? And I've mentioned it's been very different for me as I practice at different parts across the country. And then importantly, once I kind of try to understand who is my community, who am I going to partner with? We do so much about working with our community partners. So with the Cleveland Clinic, we actually did a work to kind of try to understand our communities. And we're kind of spread out here in Northeast Ohio, and Florida, and Nevada, and had a group that helped us try to have conversations and focus groups and interviews with the community to understand them a little bit better. Centering back here again, Cuyahoga County, we see the numbers of Hispanics, which might not seem very big, but again, it is growing, and it's also growing. And getting back here, the different colors here are whether it is the communities Puerto Rican, Mexican, Hispanic, or white and Hispanic. As you can see, the graphs are kind of all over the place, right? So it gets back to who is my community. And here in Cleveland, depending on the region, so where I practice in Ohio City is a largely Puerto Rican community. There's a larger Mexican and Central American community in different parts of Northeast Ohio. So understanding who's here and how do I address them. So from this Hispanic health strategy, we learned a number of things. It kind of really reaffirmed a lot of our kind of understanding of the community and how we should be thinking about the community and connected with the community. So many, the majority, felt that they actually didn't feel that they were a very good job. So this is just kind of those self-reports. And asking them, well, why and what makes it so difficult, they felt, well, it was very hard to get healthy food, accessible, healthy food. That has to be very expensive. Feeling that some of the traditionally cultural food maybe wasn't as healthy, but they didn't really know how to make a decision to healthier foods or continue to eat the foods that they enjoy in a healthier way. Thank God this is kind of uniform, the balancing work, life, family, and all the demands that make it really hard, and backing into the insurance. Kind of understanding what are those barriers to care and how can we learn about it. It's a community generally that suffers from food insecurity. So the national average for food insecurity is about 12 to 14%. Cuyahoga County tends to be much higher. Cleveland is very high as well. And Hispanic households are way above the national average. So what tying it in again to what are the barriers that we're facing if it's a community that's trying to improve their health. And sadly, depression and substance use disorder are huge burdens in this community as well. So when we ask patients like, how can we help you? How can we be there for you? And again, many reported that they're just finding that they're having challenges managing their health. And they're on what are they looking for? So they're looking for someone they can trust. We heard the word trust earlier. So what does that mean? Who can I go to if I come from a different origin, different language, different culture, or where I go that somebody would actually listen to me and that I can trust? And interestingly, even though having information in Spanish is important, and it's something that we're working towards if language is a barrier, this community really tells us, first language would be helpful, but it would be really helpful if somebody takes the time to listen to me, understand me. If they take the time to listen to me, then I can trust them that they're really invested in me. And because of the concept of cultural competence, I actually prefer the concept of cultural humility, which is really taking the time to say, let me hear about you, let me hear about you, let me hear about you and your culture and your background. And how can I try to learn to understand it? Be humble enough for me to listen so that I can deliver care that is tailored to you. Cultural competence sometimes can get us in trouble because in teaching cultural competence, we have found that sometimes people may feel like, I learned about Hispanics and I know everything about Hispanics, and that can itself be a barrier. So we need to be kind of or I guess pay attention to that. So here we have a community that's growing rapidly. So that's the line in blue and what our projections are for the Hispanic community. I don't know if you can see it at the pointer, but on 2020, there's a tiny little red dot there. The little red dot is the number of Hispanic physicians in this country. And very few of those are in academic medicine that are practicing in academic center. So very clearly, we are way behind, and very clearly we're probably never going to catch up. And how are we going to catch up? The lines probably apply just as well to the Black community. The number of Black physicians is tiny compared to our community. And again, it gets back to the concept of how do we learn about the community, how do we learn that humility and learn about the community. So again, this is why I prefer this term, is just knowing that there's only so much that I will understand, and is limited what is truly somebody else's culture, and never feeling like I know Hispanics, or I know this community, or I know the other. When we look at the community, we also have to think, well, how much of their community of origin do they have with them, and how much are they kind of acculturated to the new community, and kind of somewhere in between, right? So, depending on particularly communities that feel like when they're here, they mostly speak Spanish, they mostly kind of eat Spanish food, they mostly listen to music or TV or whatever it is in Spanish, and less acculturated, they tend to have kind of higher barriers to care here in this country. So here the numbers are higher in terms of feeling that their health is not so good. 82% face challenges managing their health, again, connected to their original conditions and the number of challenges that kind of stack up. Importantly, this is a community that, again, is very tight with the family and really relies on the family. There's actually a concept called familismo, like family, meaning if I'm going to give you medical advice, you're going to go consult with the family, and then you're going to come back and tell me if the family agrees on that. And we take that into account when we design some kind of medical programs and others, to know that we're not just treating one patient, but we're really treating the family, and that's really important. And they turn to the family for health information. We learned during COVID that they were turning to their families, and all their families were saying, so we've got to educate the families so that we can help educate the person as well. So all these things come really into play. We're really trying to make a difference and connect and have a community trust us. So if you take one of my patients, for example, they come into our clinic, we have a dedicated Hispanic clinic, all our staff is bilingual. So from the moment patients come in, they no longer need to worry about their language. About 80 to 90% of our patients are Spanish speaking only or prefer Spanish. So they come in, and at the front desk, they kind of get the their card, and we know that we can carry them through the day. But we find that, for example, I may have a patient who comes in, and I could describe many patients that I saw on Monday. They come in, I say, I just saw you 3 months ago, and we talk about all these things and how a lot has happened. What is the barrier there? What happened? Okay? And that's when we start hearing about all those barriers to care that come in for the community. So one of them, for example, is they will tell me, well, I don't speak the language, I don't feel comfortable when you speak to another specialist who may not speak Spanish. I mean, I say, by law, you would have an interpreter, and if you're not, just tell me. That's not the problem. The problem is when we call the call center, no one speaks Spanish, so we can't even get through that. That's an easy fix. So we're starting to fix that. But just kind of all these barriers that can stack up to people being able to get care. The language concordance, again, some specialties more than others. You can imagine mental health, having to explain your condition, how you're feeling. It's so hard if it's not in your language. So how can we bring that care, that specialty care, to our patients so that they don't have to deal with that? Digital access, a huge barrier during COVID. When COVID first started and the whole world turned not in person and digital, actually, I was really excited that our students from the School of Medicine reached out to me and said, we're very concerned about this community. How are we going to reach out to them? Everything, all the messaging turned out digital, right? Everything, if you're on an electronic on phone and you're on MyChart or some kind of communication with your office, everything is going out that way. This is a community that hadn't really adopted MyChart, and MyChart is not in Spanish. So stacking up the barriers of what we're going to be completely behind. So our students kind of jumped in and called patients and taught them how to use MyChart, but it's still an issue. It's still a divide. So it's something we're addressing carefully. Again, thinking just the multiple ways we communicate with the community. How do we get these resources in a way that's culturally aligned, but also important in the language that's meaningful? And then training our staff, as we just saw. We can try to increase the number of Hispanic physicians, but we're never going to get there. So we really need to be able to train and work with everyone who's already in our staff, and will be joining our staff, and will be serving our communities in that cultural humility and understanding what are the needs of the community. So we still have a lot of work to do there. just to kind of share an example, we developed this shared medical appointments. So shared medical appointments would mean kind of patients who have similar medical condition, let's say diabetes. I think in this case was diabetes and weight over BMI over 30. And you're going to bring all these patients together so they can have kind of a peer support system while also having their medical appointment. And for this particular one, we bring life coaches and dietitians and others to kind of help them with their condition. But we designed it in conjunction with the community and talking with them because we would hear from patients who suffer from diabetes or obesity that if we refer them to a nutritionist who maybe spoke Spanish, they tell me to eat all this food that I've never seen before. And it's not part of my culture. I don't know what to do with it. So we kind of learn from them. Well, how do we tailor it to something that uses your culture and really builds it into something that is healthier as they kind of all into. So kind of explain a little bit. It's a small sample, but we're now growing it and doing more of it. And to us, it's just a nice example of really building something with the community. And I want to bring up something that you brought up about having participation from different communities. There's a lot of resistance and lack of trust, really, of the healthcare system, of research, and research that has in the past not only excluded minority communities, but also being hurtful and detrimental to minority communities. So there's a lot of repair we need to do over time and find ways that we can actually engage our minority communities, our Hispanic community to be part of research, part of clinical trials, so we can learn what potentially is different and how can we better serve them. And that's, there's a lot of work on in that space locally and nationally, but just an opportunity to engage the community, but eventually will also be of service to them. This is just kind of one example that a couple of epidemiologists at the Cleveland Clinic were doing a large cohort on colorectal cancer and Parkinson's disease. And just going to the community and really trying to connect with them and letting them be part of the solution of our I think that's all I have. So I was going to just a quick run through the Hispanic community, but kind of inviting you all to kind of think through how diverse this community is, their opportunities. We actually are excited for the clinic. We're also working on multicultural health strategy. It started with working with our Hispanic community and finding out, like, how do we connect, what can we do right? Every community will be different, but we're going to take that concept so we can go to another community and learn from them and follow those practices so we can better serve.
Huge thank you to all of our experts for all the work that you do and will do and these great updates. This is phenomenal. Do we have any questions? And I will just ask you 5-ish more minutes of your time. I know that we are at time. Any questions, comments, thoughts, ideas? Yes.
This has been a really good presentation. My name is Tricia. I'm a supervisor of the ambulatory social work. And I've been hearing a lot more about the concept of weathering. And so I wasn't sure if any of you had any thoughts or insights about this concept as it applies, especially to the African American community.
I know I'm not expert in it, but I think what I've heard, I think that goes back to kind of that trauma experience over time. And so I was like, particularly when we're looking at Black women and maternal mortality, maternal morbidity, and what are all the reasons? So we know there are issues with the care that they're providing and the risks and bias that may be happening in clinical spaces. But then there's also this added stress, right? Because you've just been carrying these loads, you're seeing all this, experiencing all this vicarious racism and watch your family go through this, and you see what happens on this television. And so you have this load that you're carrying. And so that, there's in our DNA, there are little telomeres, right? And so apparently these get shorter the more stress you have. And so one of my colleagues calls it telomere shortening experience, like, your body can't even handle it anymore because it just, decreases your ability to fight off things and to stay well. And so that can be one of those things, because even like when you look at Black maternal mortality, like that, socioeconomics doesn't matter. Right? Me having a terminal degree, having an MD, I'm still just as high risk of dying in pregnancy or having a preterm birth than anyone else, and actually more likely to die than if I was like a white high school pregnant girl. Like, she'd have a healthier pregnancy than I would. And so that's part of, I think, that weathering that lifelong experience of racism. So how racism just continues to like impact us from like all these different places. So that is hard. And so that's why, you know, one, addressing the racism, but I think also having resources where we can work through all that memory down here. Thank you, guys.
Anything else? All right. Well, thank you everyone for joining us and have a great evening.